Exactly.
We're going to shift gears a little bit because I'm dying to sort of ask you a lot more questions about melanoma. And so, you're considered as one of the world, you are actually one of the world experts when it comes to melanoma. So, what, in your opinion, what are some of the major breakthrough in the last 5 years, I would say?
Yeah. So probably, and now I think we're fast forwarding to actually the therapy of melanoma rather than the prevention or the
Sure,
formation of melanoma.
sure.
So in the therapy of melanoma has been, I would say, one of the most striking stories, I would say, actually in the history of oncology, in the history certainly of modern oncology. It's probably as important as it was when people first started doing surgery altogether to be able to remove any kind of a cancer. What has happened is that we have therapies now, primarily immunotherapy, which are able to generate long-term disease control, and I think it's pretty fair to call it a cure, in a significant fraction. It's still unfortunately a minority, but in a significant fraction of patients who have metastatic advanced melanoma, where despite the fact that this disease has spread to distant organs in the body, and in some cases it can be a heavy load of that tumor, that these drugs can activate the immune system to destroy the tumor and generate what looks to us like a cure. And we're at a point where it's probably successful in the range of a third to a half of patients who have advanced melanoma. Until recently, the ability of drugs to cure advanced cancer has been limited to a tiny, tiny fraction of cancers. And in those instances, they're usually chemotherapy drugs, which, while they work well in, let's say, Hodgkin's disease, testicular cancer, pediatric leukemia, certain very specific scenarios, what has happened with melanoma is an extremely deliberate, mechanistic, basic science-driven process of understanding the pathways that the immune system uses to regulate itself, and then not just make a drug of sort of something that chew on a plant leaf and it happens to make a tumor shrink, although we'll take that if it happens, but these are actually engineered molecules that are able to activate in a designed fashion, activate the immune system and cause it to recognize the tumors and kill them. The success in that is more than 5 years now. It's been closer to 10 years,
Yep.
and that's been fantastic. In the past year, and the progress is continuing. And I'll tell you what I think is going on right now.
Yeah, that's what I'm really curious about. Yeah.
Yes. So along those lines, there are now three, I should say, classes of drugs activating different, what we call immune checkpoints, in order to, they're not activating the checkpoints, they're actually inhibiting the checkpoint to release the immune system to become active. The checkpoints exist in an inhibitory fashion, and by blocking the checkpoints, you have a double negative, you activate the immune system. And in allowing the immune system to become activated, it can kill the tumor. The first of those drugs had a modest activity, but a real one. The second of those, which was a class of drugs that targets the PD-1 checkpoint, has a huge amount of activity. And that was the lion's share of that 1/3 to a half of patients. And then most recently, there's another checkpoint that has had, again, a very modest impact, but it is now FDA approved, and it is just rolling out now, as probably will be in a combination approach, several drugs to try to really boost the ability of immune therapy to work. It's probably closer now to 50% of these patients having that activity.
So
That's
I think
one.
so
Yeah.
that everyone knows, the first one is the CTLA-4 inhibitor, the PD-1, and then you're talking about the LAG-3 inhibitor. So those are the three. And so I'm just curious, why do you think, how do we know at this point? Like, can we even predict which patient will respond is there any kind of assay, or is it something that your lab is working on to study the immune microenvironment?
Yeah, yeah, tremendously important question. And it's important for a reason that I'm about to talk about with the other big advance that's been happening, and I'll get to that in just a second. So my lab is interested in this, but so are dozens of others because it's such a screamingly important question. One of the reasons it is so important to try and predict which patients will have a good response and which will not have a good response is that, like many other drugs, these drugs can have side effects. And so, on one hand, if the drugs did not have side effects, everybody should just try them. I mean, what do you have to lose other than time, which of course is significant as well? But if they have side effects, and if on occasion those can be serious side effects, then you don't want to be giving a drug that could not work to a patient who may then have toxicity from it. And so that's why we tried to understand this. So a lot has been learned, but not everything. So what do we know? We know that tumors, which prior to the initiation of therapy, before you start treatment, when you look under the microscope at the tumor, you can see there is evidence of an immune infiltration. There are already cells of the immune system at the tumor before treatment even started. That is a very good predictor. It's not, unfortunately, a perfect predictor, but it's so strongly suggestive that this is optimistic that these drugs are going to work. There are other predictors that tend to go with this. For example, when you look for mutations in the DNA of a tumor, melanoma is one of the cancers that has among the highest density of mutations. And we can actually see from the chemical nature of those mutations that most of those were caused by ultraviolet radiation. There is a distinctive chemical feature, we call it a signature, a chemical signature of ultraviolet radiation. And that probably is part of why the immune system can recognize the tumor, part of why there are immune cells sometimes already in the tumor before any treatment even happened, because these mutations cause some of the proteins to be altered in the melanoma. And the immune system has, in all of us, has been tolerized to our normal proteins. Our immune system should not attack our normal proteins. But if those proteins have been altered a little bit, the immune system gets confused, sort of like, is this COVID? Is this influenza? Is this some foreign fungus or bacteria? What is this protein? And those mutations may actually have one good feature. Unfortunately, they contribute to the cancer risk in the first place, but they also can allow the immune system to recognize the tumor. And if you get these drugs, these checkpoint inhibitors that liberate the immune system to act on that recognition, it can actually free the immune system to attack those mutated proteins and actually kill the cells. And that is a model of what many people think is going on with this successful immunotherapy. There's no simple algorithm, though, for knowing which mutations predict who will respond to these drugs. Exactly how many immune cells you need in the tumor to predict with great specificity. But people are working very hard to try and understand what are the risk factors so that we'll have better models to predict that.
I know there's a number of clinical trials try to combine, let's say, radiation and try to combine different things. The idea is to release some of the antigen and then adding the immunotherapies. But is there anything that you guys are doing in the lab that biologically engineering or boosting this immune efficacy?
Yeah, so there actually are things that we're doing and other labs as well, which is to try and artificially inflame a tumor. There actually are certain drugs that evoke inflammation. If you think about a vaccine, that's what it does. When you're if a person gets a COVID vaccine, for example, they're getting an injection that has a key protein, the spike protein from COVID. And then they're also getting things with it that trigger the immune system to become inflamed, to be attracted to where that COVID protein is, so that it will stimulate an immune response. And so the world of vaccines and the world of other pro-inflammatory strategies, we think can be utilized to try and further activate the immune response. And if that worked, in principle, it would not be limited to melanoma, though we can certainly use more help in melanoma, but it might work in other cancers where the immune system is not sufficient currently to really produce these kinds